Good morning. I'm Kay Garamani. I'm the moderator for the panel. Welcome to the Understanding Population Health and Social Determinants panel. I'm the president and CEO of the Texas Association of Community Health Plans. And as a brief introduction to our association, our member health plans are Texas companies that are locally and regionally based. They're anchored by a health system that's either a public health system like a hospital district or a nonprofit health system. And lines of business for our plans include primarily Medicaid, but also Medicare Advantage, Marketplace, and some commercial. And I'm joined this morning by three excellent panelists. I want to let you know that after our prep session, I became very enthusiastic about this session because I think that TAHP has lined up three excellent panelists who are going to be able to share their expertise, and they each have different areas of expertise. So I think it will make for a very interesting conversation. And what I'm going to do is let you know who the panelists are. And I'm going to talk a little bit then, make some introductory comments about what the health plans have been doing in Texas around social determinants of health, mention a few statistics, and then hand it over to each of our panelists to give you an overview of themselves, the companies they work for, and the work that they've been doing around population health and social determinants of health. So our three panelists are Dr. Melissa Clark. She's with 3M Information Systems. She's down in from what I can see, she's in the middle box on the left. And then Dr. Kimberly Jeanette is a principal with Genetech. She's just raised her hand. And then our third panelist is Dr. Munish Khadija with Altrista Health. So before I turn it over to the panelists, I did just want to tell you a little bit about what the community health plans and really what other health plans, national health plans have been doing in Texas. Because I work with the community health plans, I'll speak a moment from what they've been doing because they're all affiliated with hospital systems. You know, they've been paying for services that address social determinants of health really since the beginning of their establishment. And I would say that the national plans have been doing the same. Managed care is a flexible model and it allows for things in addition to just medical care to be addressed. And the health plans have realized early on that is important for overall well-being and healthcare. And it's, I think, just social determinants of health has become a well-recognized and understood background to, overall healthcare. And I think it's been just great to see what's been happening. There's certainly been a lot more research and structure around what's going on around social determinants of health. So it's an exciting time to be in healthcare because we recognize that medical care is just one little slice of what really has to happen to make sure that a person is healthy. My association, along with TAHP, which is sponsoring this forum, have been working with Episcopal Health Foundation over the last couple of years in a partnership to do a couple of things. One is we have had an ongoing learning collaborative where we have brought together health plans to talk about what it is that each of them are doing. They learn from each other. Also, we've had this opportunity to bring in national experts so that the Medicaid health plans in Texas can learn from what is going on across the country. So that has been a very successful collaborative, and we're fortunate that Episcopal Health Foundation is going to continue to fund us with this work over the next year plus. They also did a survey of all the Medicaid health plans. They are updating that survey now, and that has given some good basic information about what the health plans are doing. And what I thought I would do is just tell you what the key areas are that the health plans have reported as being their investments in social determinants. They're the kind of things that you're gonna already know probably, but they include transportation, food, housing, employment, and utility assistance. And as I said, I'll just mention a few statistics. I don't want to take up too much time on this because I think probably a lot of you on this meeting already understand these. But as some background, The Texas unemployment rate has risen in September as compared to August. So it's now at 8.3%. That's compared to 3.4% a year ago, September. Not surprising, of course, that's what we would expect to have seen during this period of the pandemic. But it does mean that more people are in crisis. And for Medicaid, the state agency has held over everybody. They continue to stay enrolled. So the caseload for the health plans has grown by over 10%. And that will continue as long as the public health emergency lasts, which is now set for January. 1 in 5 Texas children live in poverty. That's a little higher than the national average. We also have a higher low birth weight rate in Texas overall than nationally. And of course, with Medicaid families, we certainly see Medicaid births, we see a higher rate than the national average or than the Texas average. 1 in 7 Texans experience food insecurity. So that's over 4 million individuals. And some of the health plans have been doing food drives for their membership as well as just for the community at large. So wanted to mention that they've been doing a lot of work around that. In Texas, 73% of renter households that are at or below the poverty level pay more than 50% of their income for housing. And we know that's a high risk for people then not being able to fund the other things, the necessities that they need. And so that's not a good indicator that over 50% is going for housing. And then one last statistic for you is that 41% of Texas households are considered low-income energy consumers, which means they spend a disproportionate share of their income on utility needs, 9% compared to people who are not in this low-income, this low-income group. All right, so I want to go ahead and now have our panelists introduce themselves. We will go first with Dr. Clark, then with Dr. Jeanette, and then with Dr. Kanasia. I know that Dr. Clark has a slideshow that I think is being loaded now. And so I'll turn it over to you, Dr. Clark.
All right, wonderful. Thank you, Kay, for the introduction, and thank you to THP for having me today. I'm just going to use the next few slides to sort of give a little bit about my background and the kind of work that I've been doing. So I've been really fortunate to work across all aspects of healthcare. Starting off in emergency medicine, I saw firsthand the effects of adverse social determinants of health on the patients that I took care of, which led to my research in areas like health literacy and telehealth, which eventually led me to population health. So the last 10 years or so, I've worked in various organizations on the payer side with a population health management company owned by Aetna. I transitioned to be vice president of population health for an integrated clinical network, where I gained a lot of experience around the challenges of care coordination for high needs populations. Now I'm at 3M, Health Information Systems, using clinical data to help health care organizations sort of gain insight into both their population's risk and medical complexity, as well as their own performance in meeting the quadruple aim. And so at 3M, one of the ways that we help organizations understand the health of their population is by aggregating multiple sources of data across a patient's total healthcare experience to capture their total illness burden, their actual resource utilization, and their risk of future resource utilization. And that's done with our clinical risk group model and also our core set of population-focused preventable outcome measures, which look at things like preventable hospital admissions, ED visits, and outpatient services. Providers can then use these to gauge their effectiveness of care and of the care that they're providing, and then the associated health outcomes. So social needs, finances, food, housing, all the things that Kay mentioned in her introduction are really a huge component in understanding patient complexity, and they're correlated with increased clinical risk, with preventable events and utilization. So when you combine them with these other multiple sources of data, you can really get an added dimension to understanding the reasons for risk in your population and support the development of appropriate interventions. So I just want to round this out by mentioning how some organizations have pivoted during the pandemic to address social needs. COVID has really been the unveiler of disparities in chronic disease burden, economic disparity, and healthcare access. And you can see that in this graph, understanding disproportionate death rates um, uh, with deaths by 100,000 by ethnicity. And so this is one initiative that I'm going to describe, the virtual health ministry, which is an outreach and care coordination model, that I've been involved with over the last few months that has been helping to identify and meet social needs within the African American community, not just in preventing the spread of COVID, but actually mitigating some of the social and economic disruption that it's brought. So this organization is managed by a consortium of 70 faith institutions called the Leadership Council for Healthy Communities, or LCHC. And it works like this. The faith institutions right here that are a part of LCHC do phone outreach via a shared virtual call center. They also serve as in-person distribution points for food, PPE, and COVID testing. One of the sites is actually a site for COVID testing, and soon to be flu and school-based vaccines. On the outreach calls, trained health coordinators from the faith institutions use a structured assessment to understand social and health needs, and then refer them to our service partners who are at the Howard University School of Social Work and the Howard University College of Medicine, Family Medicine Department, depending on the person's needs. The referrals are made and tracked via social services app that captures multiple data points so that we know over the last 5 months of the project that we've outreached over 6,000 individuals, sent out, done about 1,200 referrals, and sent out about 36,000 messages related to COVID-19 over various media. So there's really a potential to scale this model to use it to address chronic disease management and other health disparity conditions with a variety of potential health partners. So I'll stop there. I'll be happy to answer any questions later. Thanks.
Thank you, Dr. Clark. Let's now hear from Dr. Jeanette.
Thank you. And thanks also for that introduction. And it was wonderful to follow the slides. I'm just gonna provide a little introduction of myself. I do not have slides and look forward to hearing the next speaker introduce and then getting into the Q&A. So I'm a health services researcher and sociologist by training in the Health Policy and Systems Research Unit at Genentech. And my research focuses on social determinants of health, vulnerable populations, and health equity. I also have practical experience running an integrated health and social service program for homeless families in Oakland, California, which is part of a Healthcare for the Homeless initiative. And I've directed health and social programs at community health centers in the San Francisco Bay Area. So that's actually what sent me back to graduate school, because I wanted to learn more about ways to understand and improve systems, not just safety net systems, so that upstream root causes could either be changed or at least understood, and patient journeys could also be better understood and managed. So I'm really excited to be on this panel, and certainly in some of my answers, I'll give a little bit more of some of the experience and work I'm doing right now or have done in the recent past. And with that, I'm excited to hear from the other panel member as well and hear about the work going on in Texas and get into the discussion. So thanks for having me.
We're glad you're here. All right, I'm going to hand it over now to Dr. Kaneja for an introduction.
Hi, everyone. My name is Manish Kaneja, and as you can see, I'm a doctor at a doctor's office. So here's the wonderful world of COVID. It's a combination of working in doctor's offices. My wife's a practicing physician, so I come and help her and any days off that I have. And today just happened to be a day where I could travel. So I'm talking to you from a doctor's office. I want to start with a little bit of a story. My first experience after training, and I'll talk to you a little bit about how I got here, was my first job was actually working in a federally qualified health center. So as Dr. Dr. Clark talked about in the emergency room settings, and Ms. Jeanette has talked about in terms of her work in the San Francisco Community Health Centers. That is where you cut your teeth if you're going to first learn about social determinants of health. So how did I get my first asthmatic patient, my first asthmatic child patient who had no insurance, who was in the community health center world, one of those migrant workers that have no insurance, and there's a very small amount of money that you get to take care of those patients. I actually had a prescription for the medication made in my name, paid the $20 copay, and gave the entire box of nebulizers to the patient. That's the world of social determinants of health, where you're hoping you have medications, access to medications. And I think learning about healthcare from that lens actually helped me really understand that it's going to be really important that clinicians, researchers, and folks that you're seeing on this panel really are able to get to the other side, where we're not only working in the forefront, but actually taking all that knowledge from working in the forefront and applying it over to the vendor side of the equation. So by training, I'm a med peds physician, trained in public health as well, started in the FQHC world, then went back into the hospitalist space, again, Medicaid, safety net hospital. Used to see 200,000 visits a year. So one of the main hospitals, a flagship hospital in a very large system in New York. What I'd always was interested in is figuring out how all this connected and making sure that we had clinicians at the table to help kind of define where we're going to take this and really make sure that the patient's at the center of it. After that, I spent 7 years in the health plan space. Medicaid, Medicare first was my first experience, and then added on commercial health plans. It was Affinity Health Plan in New York, and then Emblem Health as well, and really got to understand how the benefit design, the structure of the health plan world, and everything that we do can actually influence the way an entire population, whether they be insured, underinsured, or uninsured even, or going in and out of insurance through Medicaid. The whole point is how you can support the benefit to assist those patients. After that, I was fortunate enough to be able to use my health IT training, which I had acquired along the way, and came over to Altruista Health, where now I get to lead a batch of clinicians and actually as a clinician have a seat at the table. So Altruista Health is a company that was founded in 2009. And basically we are a population health management solution. It's a misnomer a little bit, but it's really more of all aspects of care management on the technology side. For the majority of our clients are health plans, and other than that, it's risk-taking entities. Our health plans run the gamut of commercial, Medicaid, Medicare, provider-sponsored, independent, state health associations. All different aspects of the world of health plans use our care management platform to manage mission-critical pieces like care management, utilization management, appeals and grievances. How I want to talk just a little bit about the social determinants piece is what we noticed over the course of the last 5 years, and we were one of the earliest to actually hook in to the social determinants vendors who are now going out there and culling networks of providers. We figured out a long time ago, it's not about giving access to 100 different vendors and 100 different applications. It's about how can we help health plans rapidly complete social determinants referrals without actually having to go and call out networks and do that work. That job is best done by folks who are close to that world. We spend time in really trying to make sure that we're the hub so the health plans can easily get that piece done. And at the end of the day, the vendors who are taking care of these patients, the crisis respite services, the housing support services, and the food pantries, that they can all complete these referrals rapidly, get that job done, and then move on to really taking care of the patient. So really excited about this panel. I think there's a lot of good knowledge here and looking forward to the questions.
All right, thank you to the three of you. Appreciate you laying out your experiences and who you are. I think that gives people a good overview of where you're going to be coming from with the questions. For the sake of time, what I'm going to do is address a question to each of you. I will do that sequentially. if there is something that the other two panelists would like to jump in and say before we move on to the next question, feel free to do that. Just knowing that I want to make sure I get at least a couple questions into each of you. So I'm going to start with Dr. Clark. And let me give you, let's see here. What are the challenges that provider organizations have in addressing social determinants of health at the practice level, and how can they be mitigated? Dr. Clark, we cannot hear you, so want to make sure that you are unmuted.
Okay, can you hear me now?
There we go.
All right, great. So I was saying a lot of practitioners feel that it's not within their scope, or they're not currently being held accountable for addressing social determinants of health, especially if they're not practicing within a patient-centered medical home model. The others are sometimes worried that health systems, have too much to address already without sort of also trying to address social determinants of health. But we know that medical care, whether it be access or quality, only accounts for about 10 to 20% of modifiable contributors to health outcomes. The rest of them, in terms of the social determinants of health, that other 80%, which is behavior, socioeconomic status, and environment. So if we're being held accountable for the outcomes, we really have to address the social needs in some way. That being said, really integrating social determinants of health into a plan or a strategy for population health should not really fall primarily on frontline clinicians. It really needs to be taken up by the leadership of healthcare organizations to build a systems approach to integration. So support for community partnerships, attention to cultural competency, adopting a culture that really values social determinants of health, in addition to quality and affordable health care, measuring and evaluating impact, creating new skills, et cetera. So providers that are not part of health systems really are at a disadvantage and probably need to consider entering into cooperative agreements with integrated clinical networks or other groups of physicians so that they can realize economies of scale and get the support that they need in addressing and incorporating social determinants of health into the way they care for their patients.
Okay, fantastic. I'm trying to think about how best to manage this because I want to make sure we get through the questions, but I'm sure our other two panelists have a lot to say about what you just said. How about if I go ahead and just keep going through the questions, but knowing that we'll have some time at the end for you all to have some dialogue. You all have some similar experiences and expertise, and I want to make sure that we can, make sure you guys have a chance to dialogue with each other. But I'm going to go ahead and ask 2 or 3 more questions, and then we'll make sure we have time at the end for you guys to dialogue. I'm going to turn now to Dr. Jeanette. And this is your first question. Social determinants of health are often thought of as something attached to the individual, for example, education, background, race, ethnicity, or income level. How do interventions differ when they're aimed at individuals versus systems?
Thank you. Yeah. Certainly social determinants exist at multiple levels, but more attention really in the social determinants of health space in terms of practice has been spent on paying attention to something about the individual. What's their background in terms of, as you laid out, education, income, and some of those other factors. And those are really important for identifying individuals who might have potential needs and be from vulnerable populations where they may have their needs going unmet. Perhaps they don't have insurance, perhaps they live in a care desert, perhaps there's food insecurity, lots of different pieces where we want to make sure we're identifying, individuals who have unmet needs. But as many of you may be aware, we also think of social determinants of health as the places where we live, work, play, and learn. So there are environments in which we exist. And we can alter those environments to support rather than hinder health. And so a lot of my work is focused on trying to make what might seem daunting in terms of systems change very practically applied. So rather than focusing on, gosh, I can't really change the educational background of my patients or my employees. If we take work, for example, where I've spent the last 15 years of my research career helping employer coalitions understand the importance of employee health for their business. If we take work, for example, employers can do many things to support the health of their workers, even workers who are in vulnerable situations, so they can have better work-life balance policies, value-based benefits programs, supportive managers that help employees stay healthy or return to work in a healthy fashion after a period of health-related work disability, often aided by disability case managers. So, and many employers in the audience, I'm sure, and health plans as well, put these sorts of things in place in terms of trying to help those patients and employees navigate through what can seem like a daunting system. All the while, it's changing the system in the process. So by putting these sorts of interventions in place, we're starting to get a little bit more upstream to some of the root causes and understand them better. And so I do think working at both levels is important to make sure we're both doing individually focused work as well as system focused work.
Okay, great. That was a really good example that you went through. Thank you for that. All right, I'm going to turn to Dr. Khaneja. What strategies have you found to be effective in addressing the social isolation and reduced access to services that has been brought on by the pandemic?
Yeah, first let me apologize. I said Ms. Jeanette instead of Dr. Jeanette before. So there's a couple of different angles to this. I think we rapidly have seen virtual health go. Statistics are in some of the New York City hospital systems, we're finding 300 to 400 virtual visits a week became 30,000 virtual visits a week in one of the health systems. So part one of this is this face-to-face that we were actually going out and talking to each other. Some of it from the clinician, and let me separate this out. This is more the doc, the prescriber has become much more of a virtual visit as another access point. Now, we're seeing as the pandemic has run on, we're back to the hospitals. We're actually back into the offices. Some centers are even saying they're seeing more than before. And I think that's more just of a suppressed return back, and we'll see it normalize again. Some of that's going on. The interesting thing is, though, we are finding better and better ways to make the actual visit that we have easier. So in our own world, we've been spending time looking at mobile technology where, you know, instead of having 6 visits to get the same piece, John, you have one person going in to get signatures from the patient for home care visits. Then the next time someone else is going in to do one other piece of it. Then another time the nurses are coming in. So what we're trying to do is to say, well, during that visit, whenever you have your health care issues going on, can we get the signatures right then and there? That's one piece that we're offering, and that we're seeing starting to get picked up much more rapidly. So we've always had a mobile platform with the understanding that I can work on a desktop, but it might be great if I can actually sit next to the patient and have stuff done on a little laptop or some kind of an iPad structure. So we spend time doing that. The next piece is analytics, and I'll think both of my colleague presenters can talk to you about how our world would be very different if we didn't have easy access to a lot more vital information that we're getting, and the information is being shared much better. The other thing is public-private partnerships that we're finding. So we're finding that, for example, a health plan like one of ours in Colorado, we've actually been able to give them a COVID tracker and say, well, here's where the COVID numbers are going around in Colorado based upon whatever public information we have. Let's couple that public information with your private information of the healthcare that your patients are seeing, your members are seeing, and let's try to now figure out, do we have hotspots? Can we figure out what to do in those hotspots? And then, as I mentioned before, connecting into the social determinants world, we can now access that information and be able to targeted therapies. What we've learned now that the health plans more than ever want to be more targeted in their approach, because they've seen that when healthcare is not being accessed, what happens on the other side of it. We are seeing increased mortalities. We have, last thing I'll give you one, we have one health plan that's an ISNP that actually had 25% of their patient population decimated. They passed away because these were all nursing home patients. So it's about access, connectivity, the analytics to get to those patients quickly. We've seen that very helpful.
That is very interesting, what you just laid out. What I'm going to do is continue through the questions. However, if panelists have something to say about a question that was asked of another panelist, you can start off or end by commenting on your other panelists' responses. Okay, I'm going to go back to Dr. Clark. How can you capture SDOH data accurately and in a meaningful way to define patient complexity and inform interventions? I think this question feeds nicely into the comments that we just heard from Dr.
Yeah.
Kanisha.
Yeah, I was just thinking that actually. Yeah, so at the practice level, certainly screening for social determinants of health, using assessments, and then incorporating that information into a care plan is very effective for that particular practice, especially if the data is shared over the organization. But at the systems level, in organizations where decisions are being made about system level interventions and value-based contracting and payments, that data, that social determinants of health data rarely bubbles up to the surface when you're looking at aggregate outcomes and understanding the risk of the population that you're serving. Um, Oftentimes that is the case because it's not being accurately captured in the medical record and then being coded for accurately. So another way is to work with data aggregators who take third-party social determinants of health data, like a partner that we work with, Socially Determined, and then be able to use that data and combine it with other multiple sources of clinical data to get a better refined understanding and an assessment of the risk of your population, and therefore be able to understand best what interventions can be brought to bear. And those those data aggregators really sort of break things down on the individual level in terms of risk, but they also look at neighborhood factors such as housing quality in the neighborhood, food, transportation access, average educational attainment in the neighborhood to help understand an individual's risk who might live in that neighborhood as well.
Okay, great. Thank you. And then I'm going to turn now to Dr. Jeanette. One concern we hear often is around social determinants of health, is that it is difficult to change a system. And you had pointed out that it's like boiling the ocean. And I would like to ask you to provide some examples of modifiable systemic factors.
Yeah, thank you. Flows really nicely from Dr. Clark's explanation just now and the earlier ones as well. I touched on this a bit with the work example, the employment example I gave earlier, but I'll provide an even more complex example since I still do hear that like boiling the ocean comment a lot. And so a lot of my focus is on, while we're doing all the very specific practice-oriented changes that are individualized to individual patient needs, there are also some really wonderful opportunities to generate data systems, and we've talked about that a bit already. And so the example I'm going to give is back in the 90s, I worked on a study for RAND, and we focused on the patient journey through a large health and social service system, and this was actually in Houston. We also did this study in Los Angeles and New York, in Manhattan, and we were able to obtain administrative data from leading healthcare providers, as well as community-based and FQHC providers, mental health providers, social service, homeless shelters, and even criminal justice. We integrated that data, so this is way back in the 90s, so it was quite a task. And we focused, the point was to see what would this information help us see that we couldn't see given the current setup and systems that were in place for each individual isolated organization. So what we focused on were individuals who had mental health and comorbid substance use problems. And we assembled these data sets across these sectors. And for the first time, we were able to show the providers an evidence-based view of how patients move through the system, where they get blocked, where they may miss an opportunity for more appropriate care. For example, stays in jail as opposed to mental health or substance abuse treatment. And being able to do nowadays with the technology we have, resource mapping in a local community, identifying where there are health and social service assets, that's been spoken to a bit already. Opportunities for improvement where there may be care deserts and maybe difficulty accessing high quality care. And having evidence-based accountability systems in place that use data on real utilization and real experience of patients and residents. Because just patients isn't good enough. Those are people who are getting into the system. So we also have to have a way of understanding where we have unmet need. And this speaks to the point about sometimes the data we rely on may be missing either important features of social determinants of health or only measuring individuals who might already be hooked into a patient-centered medical home or know where they can go for care. And I've seen this type of approach work very well in my local county. I'm not from Texas. I'm sure there's some great stuff going on in Texas as well. But Contra Costa County, my local county, is doing some wonderful work with homeless individuals and helping to prevent periods of homelessness. And that problem in and of itself can be a wonderful a focal point for local communities because it requires attention to all the sectors we've been talking about. So if you try to tackle homelessness in your community, you have to deal with health, food insecurity, housing costs, all the things we can think about, employment opportunity. So I think I do see it working. I think it isn't like boiling the ocean. You have to have multiple stakeholder groups together if you want to do systems change in addition to individually targeted treatment focused on social determinants. So thanks for the question, and I'm happy to hear that others are working on systems change as well.
There is definitely some overlap, and it's really great to hear about just the synergy among our panelists because you're coming at it from different angles, but I think you're all concerned about the same things and you are focused on very similar things, such as data, systemic issues. And so this has been really interesting for me to hear your responses. I'm going to turn now to Dr. Khaneja. You're welcome to comment on what Dr. Jeanette said, but I'm going to ask you also another question, which is, are there any lessons learned from initial round of the pandemic that we would do differently going forward? Oh, that's a big question. Let's hear what you have to say, Dr.
We would, I echo Dr. Jeanette's comments, actually. There's nothing that it is about the data, the systems connectivity, and we have to hit it from multiple angles. What could we have done differently? As a clinician, so let me use both hats for a second. As a clinician, science and data must drive our decisions. We don't want to believe the science because it hurts when you're not allowed to go in to see a patient. So let me give a great example of something that same place that had the iSNP issues. We heard horror stories about refrigerated trucks for dead bodies, right? And I'm being graphic about the conversation, but it's how we would have done things differently is using data and science to plan out things better. The question that they were given is, okay, we have people that are dying at much higher volumes in nursing homes, and funeral directors and funeral homes are fully packed, and you also can't send anywhere else. There's no city morgue. The morgues are packed. What would you do? The structure needed to be, if there is an overflow of such issues, what do you have? The only answer that anybody could provide was these refrigerated trucks because there was no other place. You cannot risk the patient next door. You cannot risk the staff. But the endpoints where the outputs would have gone of this situation were not managed. So I would say to you, the biggest thing, the most important thing we needed to do, and we can keep doing, is let's use data to drive our direction. I think we're all happier seeing that we have much easier access to number of cases and regions down to zip codes in many places that are doing mass testing. And we can actually say, okay, in this zip code, I'm seeing increases and decreases in processes. We're cohorting, movements of people at 10 at a time, things like that, just gatherings being managed. That's the data pieces that we could use. And now having more of that data that we can overlay in all of the systems that we're doing. So some of it I know my colleagues at 3M are doing that kind of work too, where they're bringing in many more aspects of that process. There's now artificial intelligence being used in there. And I think you mentioned socially determined already. That's already working on that as well. Unite Us is working on use that as well. So there's the movement of being able to take that data and plan forward. Um, Supply chain management is probably the most important thing that we can do better next time. And I think health plans really have a big say in this because they also have the best longitudinal data to say, okay, what happened 5 years back in Medicare? What happened 5 years back in Medicaid that we can hit and say, okay, this is the data we know that when big changes happen by a benefit or something like that, what can we do? Now apply a pandemic to that, which will still give you the same stressors and test that process. So that would be those would be the few things that I think we should do differently. And we have now the data to manage it.
All right, thank you. Wonderful responses from all three of you. We have just 4 minutes left. I'm going to turn to the two Q&A questions we have. The first one I'm going to ask, I will throw out to all three of you. The second one is specifically asked of Dr. Clark. So the first question I'm going to ask is, looking forward, what does it look like? Do we anticipate new or more social barriers because of COVID? And what are future opportunities? So looking forward, what does it look like? Do we anticipate new or more social barriers because of COVID? And what are future opportunities?
Is this open
Well,
or you'd like to go? Go ahead, Dr. Clark.
Oh, I was going to say, I think, you know, there are going to be more barriers because of COVID-19, because of the economic disruption, higher levels of unemployment, more food insecurity, et cetera. But I think there have been some really important strides made in terms of access with the rise of telehealth. I used to be a board chair at a federally qualified health center here in Washington, D.C., and I co-wrote an article with them that came out about the increased use of how telehealth is helping the underserved populations, which it was thought that there might not be that opportunity. So Medicaid payment models that have changed in various states to allow this, there's an opportunity to continue those forward to increase access to care. Then the model that I described earlier in terms of community-based organizations and really finding models that work in terms of outreach and bridging the gap, the health disparities gap, where health organizations might not be that trusted entity, but using certain criteria to determine who are the trusted entities around track record, reporting capabilities, data management capabilities, and outreach into the community. Those are definitely new horizons. And then, of course, the technology that can be brought to bear. I was a mentor in the MIT hackathon against racism in healthcare this past weekend. It was really fun experience, and it was wonderful to hear all the ways that apps can be brought to bear, not just to address issues around COVID, but systemic barriers in care. So lots of those coming down the pike.
All right. Well, I think also we have hit, at least touched on, Dr. Clark, you did, on the second question that we had, because we have 3 or 2 minutes left. Just want to ask if anybody has any final comments. Dr. Jeanette, anything? I'll just turn to you. Anything that you'd like to say to wrap things up?
I think it sounds like we're all converging on very much the same idea, which is in many ways, the best change is local change, right? It has to be based on community assets, including public-private partnerships. And right now, there really is very little integration, coordination, and collaboration between the public health system or the safety net system and the private healthcare system. Although there's promising work being done in many communities, and I'm sure it's happening in Texas as well. But part of those assets in the community include the trust that Dr. Clark was talking about. And so being able to see where those assets currently exist, which often is in the public health safety net system, and being able to build upon that. And it's going to take the private healthcare system, or at least let's say the traditional players who often have FQHCs associated with their university-based delivery system, it's going to take a lot of good training on their part as well, in terms of bias training, in terms of being able to kind of step up to the plate and with some humility and being able to better understand what the assets in a community are, and use evidence, as a multi-stakeholder group coming together, using evidence over time to see where are we moving the needle, where are things improving, where aren't things improving, and through discussion using evidence and science, being able to keep moving forward and improve.
I think just to wrap things up, you all have really demonstrated how research, social science, data analytics has become a lot more sophisticated in this area. It's been really interesting to hear how you are each coming from different companies. Maybe you all didn't even know each other before this panel, but you all certainly have. There's a lot of commonalities among what you all are doing. So it's encouraging to see, from the managed care health plan perspective, that there is so much talent out there. Appreciate everybody's time. Sorry we have to wrap things up, because I think we could continue to go on for quite a while with this topic, but want to really thank our 3 panelists and thank TAHP for giving us this opportunity to put out this panel to people. And I have a feeling that all of us will be talking about social determinants of health into the future, at least as much as we are now, if not more. All right. Thank you, everybody.
Thanks for having
Thank
us.
you.
Thank you.
Bye.
Bye-bye.
Thank you very much. Bye.